In a pediatric cardiology clinic, 4-year-old Tara is brought in by her parents because she has not been acting herself over the past month. The mother also mentioned that she can't keep up with the other children when playing, and often gets fatigued or short of breath. Vital signs include a temperature of 37 degrees Celsius, or 98.6 degrees Fahrenheit, a heart rate of 100 beats per minute, a blood pressure of 110 over 70 millimeters of mercury, and a respiratory rate of 18 breaths per minute. On examination, her skin is pink, and auscultation of the heart reveals a holosystolic murmur over the left sternal border. So Tara has some sort of congenital heart defect. Congenital heart diseases are defects in the embryological development of the heart or its major blood vessels. When the defect causes blood to move from the right to the left side, it's called a right-to-left shunt. This is because deoxygenated blood from the right side goes to the left side, and then enters the systemic circulation. A large amount of deoxygenated blood in the systemic circulation gives the physical appearance of cyanosis, which is a bluish discoloration of the skin. Therefore, left-to-right defects are called cyanotic heart diseases. Conversely, left-to-right shunts are called acyanotic heart defects, because there is no cyanosis. In general, individuals with acyanotic congenital heart diseases could be asymptomatic, or present with signs of heart failure, such as exercise intolerance, shortness of breath, and in the cases of infants and young children, poor feeding and failure to thrive. Okay, of the acyanotic congenital heart diseases, ventricular septal defect, or VSD, is the most common. The ventricular septum normally separates the left and right ventricles, and is made of a membranous component, which is the upper 1/3, and a muscular component, which is the lower 2/3. The defect most commonly occurs in the membranous portion of the septum. Ventricular septal defects are usually small, and they often end up closing on their own. Individuals are asymptomatic at birth, and if symptoms develop, they usually occur a couple of weeks later or even later in life. This is a helpful clue on exams. On auscultation, a systolic murmur can be heard along the left sternal border. Bear in mind, though, that the smaller the defect, the more audible the murmur. That's because when blood rushes through a more narrow opening, it produces more turbulence and therefore more noise. In addition, because the defect allows oxygenated blood to move from the left to the right side of the heart, the oxygen saturation will be higher than normal in the right ventricle and the pulmonary artery. Okay, now let's move up the heart and look at atrial septal defects, or ASD. Remember that an atrial septal defect is different from a patent foramen ovale. Normally, when the heart is first developing, a strip of tissue called the septum primum between the left and right atria grows downward, slowly creating two separate chambers by closing a gap, or opening, known as ostium primum. The septum primum then fuses with the endocardial cushion and closes the gap completely. Meanwhile, a hole appears in the upper area called the ostium secundum. Now, we also have the septum secundum, which grows downwards, just to the right of the septum primum, and covers the ostium secundum, leaving a small opening called the foramen ovale, which allows blood to go from the right atrium to the left atrium. At birth, the septum secundum and septum primum slap shut, and then fuse and close off the foramen ovale. However, for your exams, it's important to know that the foramen ovale remains patent in approximately 25% of normal adults. A high-yield fact is that the most common atrial septal defect is a problem with the formation of the septum secundum, and it's specifically called an ostium secundum defect. Ostium secundum atrial septal defects are usually isolated, whereas the less common ostium primum defects typically occur in association with other congenital cardiac anomalies. A high-yield association of ostium primum defect is with Down syndrome, or trisomy 21. Similar to ventral septal defects, individuals are usually asymptomatic. On auscultation, the most characteristic feature of an atrial septal defect is the fixed split S2. Normally, during inspiration, the S2 heart sound actually splits into two separate sounds. That's because during inspiration, there's negative pressure in the chest to bring in air. That negative pressure also brings a bit more venous blood back to the right atrium and right ventricle. So it takes a little more time for the right ventricle to squeeze this extra blood into the pulmonary artery, and it takes a little bit more time for the pulmonary valve to close. This can be heard as physiological splitting of the S2 during inspiration, where the pulmonary valve closes a bit later than the aortic valve. Now, with an atrial septal defect, there's extra blood that gets shunted from the left atrium to the right atrium and right ventricle, which passes by the pulmonic valve and causes a delay in the closure of the pulmonic valve relative to the aortic valve closure, producing a split S2. But since the atria communicate via that defect, inspiration produces no net pressure difference between them and has no effect on the splitting of S2. So, S2 is fixed, meaning that it's split to the same degree during inspiration and expiration. Now, similar to ventricle septal defects, the oxygen saturation will be increased in the right ventricle and pulmonary artery. Saturation will also be increased in the right atrium, and this is what distinguishes atrial from ventricular septal defects. An important complication of both a patent foramen ovale and an atrial septal defect is the development of paradoxical emboli from the venous circulation. Say someone develops a deep vein thrombosis in their legs, from which an embolus breaks off and travels up to the right heart, but instead of going from the right atrium to the right ventricle into the lungs, it passes through this atrial septal defect to the left atrium, and then to the left ventricle, and the systemic circulation. This may lead to the development of a stroke once the embolus travels up the carotid arteries and gets lodged somewhere, and this is specifically called a cryptogenic stroke. Alright, now we go up even higher in the heart to look at patent ductus arteriosus, or PDA. Now, in utero, the ductus arteriosus is the normal communication between the pulmonary artery and the aorta. The structure serves to shunt blood to the baby's systemic circulation from the pulmonary artery to the aorta, so from right to left. This is important because the fetus's lungs aren't working yet, and blood doesn't really go there. This is all normal, and it's maintained by high levels of the vasodilator prostaglandin E2, which is produced by the placenta and the ductus arteriosus. At birth, a bunch of things change. First, oxygen levels in the blood go up dramatically, and the lungs become the main source of oxygenated blood. Soon after birth, the foramen ovale closes, and prostaglandin E2 levels fall, causing the ductus arteriosus to close off and eventually become the ligamentum arteriosum. If it fails to close, it's called a PDA. This might happen if, for any reason, oxygen tension is low. For example, if a baby is born prematurely, their lungs haven't fully developed yet, so they can't maintain normal levels of oxygen in the blood, and the ductus fails to close. Another high-yield association is congenital rubella infection. Okay, now in PDA, blood moves from the aorta to the pulmonary artery, so left to right. This happens because the pulmonary vascular resistance decreases after birth, switching the direction of the shunt. So all that oxygenated blood is going back to the lungs instead of to the systemic circulation. Now for your test, keep in mind that in 90% of cases, PDAs occur as isolated defects. But in the remaining 10%, they are associated with other congenital heart defects. In fact, in certain cyanotic congenital heart defects, where the right ventricular outflow is obstructed, like in tetralogy of Fallot, or where the aorta and pulmonary artery swap locations, like in transposition of the great vessels, PDA is necessary for survival. That's because it forms a connection between the aorta and pulmonary artery that allows mixing of oxygenated and deoxygenated blood during fetal development. Now, here's where anatomy knowledge kicks in. The ductus arteriosus originates in the arch of the aorta, below where the subclavian artery branches. And remember, the subclavian artery supplies the upper limbs. So every time a PDA is not corrected, babies eventually present with normal pink upper limbs, but pale or even cyanotic lower limbs, which is called differential cyanosis. Okay, now comparing it to the septal defects, oxygen saturation will be increased only in the pulmonary artery, and will be normal in the right ventricle and atrium. On auscultation, a PDA produces a continuous, machine-like murmur that's best heard over the left clavicle. PDAs are usually treated with indomethacin, a non-steroidal anti-inflammatory medication which blocks the synthesis of prostaglandin E. If this fails, surgery is often necessary to close it. Alright, now if any left-to-right shunt is not corrected, then a long-term complication called Eisenmenger syndrome can occur. Over time, constant shunting of the blood to the right heart increases pulmonary blood flow. Because the pulmonary vessels are now receiving more blood than they're used to, they remodel their anatomical structure, known as vascular remodeling. Although this seems normal, vascular remodeling causes an increase in the blood pressure in the pulmonary vessels. In other words, pulmonary hypertension. Now the right heart has to pump against much higher pressures than it's used to, so it too undergoes remodeling in the form of right ventricular hypertrophy. This causes the pressure of the right heart to go up until it reaches a point where it's higher than the left heart, which switches the direction of the shunt. Now that it's right to left shunt, individuals begin to develop cyanosis and hypoxia. In response to the decrease in oxygen saturation, or hypoxia, the interstitial cells of the kidney make more erythropoietin, which signals to the bone marrow to produce more red blood cells to compensate for the hypoxia. This results in polycythemia, or elevation of the hematocrit. Another sign of chronic hypoxia is the clubbing of the fingers and toes. So again, although these are termed acyanotic diseases, without proper treatment, individuals will eventually develop cyanosis due to Eisenmenger syndrome. Okay, now the final acyanotic congenital heart disease is coarctation of the aorta. Unlike the disorders we talked about, there is no shunt here. Coarctation of the aorta is a narrowing of the aorta and is classified into two types: preductal, also called the infantile type, and postductal, also called the adult type. This is based on the location of the aortic narrowing in relation to the ductus arteriosus. In the infantile form, the coarctation develops early in life and the ductus arteriosus is still open. So we have a PDA. Now, in a PDA, we mentioned that the blood is shunting from the higher pressure left side, or the aorta, to the lower pressure right side, or the pulmonary artery. But when there's coarctation before the ductus arteriosus, the pressure is now lower in the aorta compared to the pulmonary artery. So now, deoxygenated blood moves from the pulmonary artery to the aorta. And because this happens after the aortic arch branches, the infant develops differential cyanosis, or cyanosis of the lower extremities. On the other hand, the adult type of coarctation happens after what is now the ligamentum arteriosum, so they do not develop differential cyanosis. This is the main difference between the two types. In both types, because the narrowing occurs after the aortic arch branches, blood has a hard time getting through. So the blood pressure is higher proximal to the narrowing, but is lower distal to the narrowing. This is reflected as high blood pressure in the upper extremities, but low blood pressure in the lower extremities. But the thing is, we don't usually check lower extremity blood pressure routinely, so exams can bring coarctation as a case of hypertension that was not resolved with medications. Now, if you put one finger on the brachial artery and another on the femoral artery, you should normally feel the pulses right around the same time, and they should be of equal strength. But in coarctation, the femoral pulse is quite delayed, and it's relatively weaker than the brachial pulse, and this feature is called brachiofemoral delay. In addition, the narrowing increases blood flow to the brain, which increases the pressure in the cerebral circulation, putting individuals at risk of cerebral hemorrhage. The narrowing also causes the afterload to increase, which is the pressure the left ventricle has to pump against. So a logical complication of this is left ventricular hypertrophy and potentially heart failure. Other, more rare complications include aortic rupture and endocarditis of the aortic valve. Another important clue is rib notching. See, normally the intercostal arteries supply the ribs. The anterior intercostal arteries come from the internal thoracic artery, a branch of the right subclavian. And the posterior intercostals come from the descending aorta. This anatomy actually provides a collateral circulation to bypass the narrowing, which is good. But the problem is these intercostal arteries are now under such high pressure that they eventually dilate. These dilated arteries rub up against the ribs, and over time, the ribs can develop notches that can be seen on a chest x-ray. For your test, there are some high-yield disorders associated with coarctation of the aorta, such as Turner syndrome and bicuspid aortic valve. Alright, as a quick recap. Congenital heart diseases are defects in the embryological development of the heart, and can be broadly classified into cyanotic and acyanotic defects. Acyanotic defects are characterized by left to right shunt, with the exception of coarctation of the aorta. The most common acyanotic defect is ventricular septal defect, which usually occurs in the membranous portion of the septum. On auscultation, a holosystolic murmur is heard over the left sternal border. Atrial septal defect usually happens in the septum secundum, and auscultation may reveal a fixed, wide splitting of the S2 heart sound. A patent ductus arteriosus usually happens in infants born prematurely, and is also associated with congenital rubella. Auscultation may reveal a continuous machine-like murmur over the left clavicle. Over time, any acyanotic defect with a left to right shunt can be complicated by Eisenmenger syndrome, which is reversal of the shunt direction to become a right to left shunt, causing the individual to develop cyanosis. Finally, coarctation of the aorta is narrowing of the aortic arch and is classified into the infantile and adult forms. In infants, the narrowing happens proximal to patent ductus arteriosus, and infants present with differential cyanosis, which is cyanosis in the lower extremities. In the adult form, individuals often present with hypertension in the upper extremities and are at risk of complications like heart failure and cerebral hemorrhage. Going back to our case, if we put Tara's clinical picture together, she has shortness of breath and fatigue on exertion, which can be caused by the various congenital heart defects we've discussed. The key clue is that on examination, there's a holosystolic murmur over the left sternal border. This is consistent with a ventricular septal defect. Tara underwent surgical correction of the defect and is now keeping up with her friends.
The atrial septum separates the right and left atrium of the heart, and an atrial septal defect describes where there's some opening in a baby's heart between these two upper chambers. But how does this opening form? Well, let's first run through how the septum develops in the first place. When the heart's first developing, a tissue called the septum primum between the left and the right atria grows downward, slowly creating two separate chambers by closing this gap, or ostium primum, which means the first opening. This septum primum then fuses with the endocardial cushion and closes the gap completely. Meanwhile, a hole appears in the upper area called the ostium secundum, or second opening. Now we also have the septum secundum, which grows downward just to the right of the septum primum and covers the ostium secundum like a curtain, leaving a small opening called the foramen ovale, and essentially creating a makeshift valve that allows blood to go from the right atrium to the left atrium, but not the other way.
The developing fetus gets oxygenated blood from the placenta, which goes from the umbilical vein over to the right atrium, which is different because after development, only deoxygenated blood goes to the right atrium, which is then sent to the lungs to pick up some oxygen.
In the developing fetus, though, it's already oxygenated, so instead of going to the right ventricle and to the lungs and back to the left atrium, it just bypasses the right ventricle and lungs through the foramen ovale and into the left atrium. The oxygenated blood then goes to the left ventricle to be pumped to the body. At birth, the septum secundum and septum primum slap shut and then fuse and close off this foramen ovale, so we can rely on our own lungs for oxygen. An atrial septal defect, or ASD, describes a condition where in some way the septum between the right and left atrium doesn't close up all the way and remains open even after birth.
Most ASD cases are due to the ostium secundum, which can happen when the secundum septum doesn't grow enough during development. This actually accounts for about 10 to 15% of all congenital heart defects and is the most common congenital heart defect in adults. Fewer ASD cases are due to the ostium primum, where the first opening, or ostium primum, doesn't make it all the way down, again leaving an opening between the right and left atria.
This primum type of congenital defect is found in around 25% of patients with Down syndrome. Atrial septal defects, in general, are also commonly associated with fetal alcohol syndrome. Okay, so there's this opening in the septum. Now what? Well, you know how pressure's higher on the left side than on the right? Well, this pressure difference causes blood to be shunted from the left atrium to the right atrium, meaning more oxygenated blood gets over to the right side, which is usually deoxygenated blood, right? This type of defect is an acyanotic heart defect, which means not blue, since oxygenated blood is going into the pulmonary circulation and essentially taking an extra trip to the lungs. In contrast, a cyanotic heart defect allows deoxygenated blood to bypass the lungs and make it out to the body, causing a blue or purplish discoloration of the skin, which is not the case here. That being the case, you'll see an increase in oxygen saturation of the blood in the right atrium, the right ventricle, and the pulmonary artery. This extra blood volume passing by the pulmonic valve also causes a delay in the closure of the pulmonic valve relative to the aortic valve closure. This slight delay can be heard via auscultation as a splitting of the S2 sound, as well as a systolic murmur in some cases. One potential complication for patients with an ASD is if the patient develops an embolus, let's say a blood clot because that's the most common type, that makes its way through the ASD. So if we take the example of a person with a deep vein thrombosis, part of that blood clot might break loose and become an embolus, and usually this guy would travel into the right atrium, then the right ventricle, and then be pumped off to the lungs and lodge somewhere in the lung. it's possible that the embolus crosses over to the left side, in which case it can enter the systemic circuit and potentially lodge in the brain. This situation is called paradoxical embolism. Paradoxical because the embolus starts off on the right side, but then crosses over into the left side. Sometimes children with ASDs will be monitored for a little while, since smaller openings might close on their own. In other cases, though, especially for larger openings, surgery will be done to prevent complications in the future, which typically involves plugging or patching the opening.
Alright, as a quick recap. An atrial septal defect is a congenital heart defect where the septum between the right and the left atrium doesn't close up all the way, and remains open after birth. This causes oxygenated blood to get into the pulmonary circulation. One complication from this condition is paradoxical embolus, which crosses from the right to the left side via the ASD.
Coarctation's a fancy way of saying narrowing. So a coarctation of the aorta means a narrowing of the aorta. If we look at the heart, we've got the right and left atria, the right and left ventricles, the pulmonary artery leaving the right ventricle to the lungs, and the aorta leaving the left ventricle and going to the body. There are two forms of aortic coarctation to be familiar with, an infant form and an adult form. With the infant form, which accounts for about 70% of cases, the coarctation comes after the aortic arch, which branches off to the upper extremities into the head, and before the ductus arteriosus. Now you might be thinking, hey, what's this ductus arteriosus thing doing here? Well, typically this guy only exists during fetal development and closes after birth. But with infantile coarctation, the ductus arteriosus is usually still open or patent. So there's a patent ductus arteriosus. In fact, sometimes this form is also called preductal coarctation. So if we draw out a little more simplified version of the heart, we've got deoxygenated blood coming into the right atrium and then flowing into the right ventricle. Now, as it's pumped out the pulmonary artery, it's got two choices, right? One option is to go through the patent ductus arteriosus and continue down the aorta instead. And the other option is to continue on down the way it's going. Well, since it's higher pressure over here on the left side, you might think that blood would say thanks, but no thanks, and keep going down the lower pressure pulmonary artery. But this aortic coarctation adds a little twist. Since this spot, right before the ductus arteriosus, is narrower, blood flowing from the left side has a harder time going through. And so actually there's a high pressure upstream of the coarctation, but low pressure downstream. So what happens is that the blood actually decides to go this way through the patent ductus arteriosus and into the lower pressure area over here in the systemic circulation, and then continue down to the lower extremities, rather than the slightly higher pressure pulmonary artery. And this gives you a real sense for exactly how much this coarctation reduces the pressure over here on the systemic side. Alright, since deoxygenated blood's going to the lower extremities, infants typically present with lower extremity cyanosis, meaning a blue or purplish discoloration of the lower limbs, which is often present even at birth. And this is a really important thing to catch because without intervention, infants often don't survive past the neonatal period. Infantile coarctation is something that happens during fetal development and can occur on its own, or it can be associated with other congenital changes. It's worth mentioning that it's highly associated with Turner syndrome, a genetic abnormality where females only have one X chromosome instead of two. Alright, so this brings us to adult coarctation, which accounts for the other 30% of cases, and this typically develops as an adult. Compared to infantile coarctation, in this type there usually isn't a patent ductus arteriosus, and instead it's been long since closed off and is now known as the ligamentum arteriosum. The coarctation usually happens in adults just distal to this ligament. So now in this case there's no mixing of deoxygenated and oxygenated blood. But just like an infantile coarctation, the pressure's increased before the coarctation since blood has a harder time squeezing through this narrowed artery. And it's going to be lower downstream from the coarctation. Alright, so this results in a couple issues. First, upstream issues. Blood flow increases into the aortic branches, and therefore blood pressure increases in the upper extremities in the head. Increased cerebral blood flow means an increased risk of Barry aneurysms, where weak spots along blood vessels in the brain balloon out from high pressures and become tiny sacs filled with blood. This increased pressure also tends to cause the aorta and aortic valve to dilate or get larger, and the increased pressure means the aorta is at risk of aortic dissection or tearing of the inner layer of the aorta. Now for downstream issues. Since blood flow downstream from the constriction is decreased, there'll be decreased blood pressure in the lower extremities, and the patients will have a weak pulse in those lower extremities. Since blood pressure is lower, patients sometimes experience claudication in their legs, which is pain and cramping due to reduced perfusion. Also, when less blood is perfusing to the kidneys respond by activating the renin-angiotensin-aldosterone system, which results in water retention and ultimately increases blood pressure and causes hypertension. Alright, so coming off the aorta, you have these smaller arteries called intercostal arteries that run alongside the ribs and supply blood to the area between the ribs, the intercostal space. Keeping aortic coarctation in mind, some of these branch off above the constriction, and they're called anterior intercostal arteries, and they branch from the internal thoracic artery, which is off of the subclavian. And some of these branch off below the constriction, and these are the posterior intercostal arteries that come directly from the thoracic aorta, and they supply ribs 3 and below. It actually turns out that the posterior intercostal arteries serving ribs 1 and 2 come off above the constriction as well. Okay, so upstream, you have this increased pressure in the aorta, causing increased pressure in the subclavian, internal thoracic artery, and then anterior intercostal arteries, and the first 2 posterior intercostal arteries. And then you have decreased pressure below the constriction in the posterior intercostal arteries for ribs 3 and below. Now what you need to know is that these arteries are normally linked up to form an anastomosis, which means that there's this direct connection between these anterior and posterior arteries. Under normal circumstances, though, pressure is equal in the anterior and posterior arteries, so blood flows away from the heart, as expected. But now that we have this high pressure system in these anterior arteries and low pressure system in the posterior arteries for ribs 3 and below, you actually get reversed flow in the posterior intercostals. These posterior intercostal arteries dilate to accommodate the high pressure, and when the heart beats, they pulsate and literally rub up against the ribs, slowly wearing away the bone. And this can be seen on X-ray as rib notching, typically only affecting ribs 3 through 9, but particularly affecting ribs 3 and 4. Also, because there's a high pressure in both the anterior and posterior intercostal arteries for ribs 1 and 2, there's no reversal of blood flow, and you don't typically see rib notching there. Alright, so there are a couple treatment options for adult aortic coarctation, which are balloon dilation, where a tiny balloon is used to widen the aorta, as well as having the narrowed area of the aorta surgically removed, which can correct the hypertension. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Patent, not patent like an invention, refers to some opening, and a patent ductus arteriosus, which I'm going to call a PDA for short, refers to a blood vessel, the ductus arteriosus, which connects the pulmonary artery to the aorta during fetal development. The ductus arteriosus is right on the aortic arch, where vessels are branching off to the brain and upper extremities. Alright, so to help visualize this, I'm going to switch to this super simplified version of the heart, since it's better at showing the relationship between the aorta, the branches, the pulmonary artery, and the ductus arteriosus. But we'll keep the more anatomical heart for reference. So this vessel, the ductus arteriosus, usually closes after birth, because the walls collapse down and it becomes a ligament, the ligamentum arteriosum. But when it stays open after birth, we call it a patent ductus arteriosus, because it's still passing blood through it. In other words, it's still patent. Now, during development, the fetus doesn't use the lungs yet, and relies on oxygenated blood from the placenta that comes into the right atrium. Most of that blood actually flows through the foramen ovale, an opening between the atria. Blood that doesn't make it through the foramen ovale is pumped out of the right ventricle to the pulmonary artery, at which point most of it gets sent to the ductus arteriosus to the aorta instead of to the lungs. Because remember, the fetus isn't using the lungs yet. During fetal development, the ductus arteriosus is kept open by high levels of a vasodilator called prostaglandin E2, which is made by the placenta and by the ductus arteriosus itself. At birth, a bunch of things change though. Oxygen levels in the blood go up dramatically, and the lungs become the main source of oxygenated blood. Soon after birth, the foramen ovale closes and prostaglandin E2 levels fall, causing the ductus arteriosus to close off. The lungs also start to release a small peptide called bradykinin, which constricts the smooth muscle wall of the ductus arteriosus and sort of helps the process along. Within the first day, the ductus arteriosus usually starts clamping shut, and within 3 weeks it's completely closed off and turned into the ligamentum arteriosum. If that ductus arteriosus doesn't close off, then the baby is left with a patent ductus arteriosus, and this condition accounts for about 10% of all congenital heart defects, of which the vast majority, about 90%, are isolated heart defects, meaning there aren't any additional congenital defects. On the other hand, a PDA can be associated with other congenital problems. For example, congenital rubella syndrome, where the mother contracts rubella virus during her pregnancy. Alright, so now we've got this still open ductus arteriosus, and we're using our lungs. Now what happens? Well, as blood comes into the right atrium, and then goes to the right ventricle, it approaches the ductus arteriosus and has two options. Keep going down the pulmonary artery, or reroute to the higher pressure system in the aorta. Well, since blood likes to move from high pressure to low pressure, and it's higher pressure over in the aorta, it actually just keeps going onto the lungs. Then that freshly oxygenated blood comes over into the left atrium, the left ventricle, and now again it has a choice. But this time it's already in the higher pressure system, and now some of it is shunted back to the lower pressure system in the pulmonary artery. At this point, the shunt is left to right, so oxygenated blood is flowing back and taking a second unnecessary trip to the lungs. What we don't have is any deoxygenated blood escaping into the systemic circulation and causing the baby to appear cyanotic, so we call this acyanotic, which means not blue. Usually this situation is asymptomatic, and patients can have what's known as a continuous murmur, also known as Gibson's murmur, from blood moving from the aorta to the pulmonary artery. Continuous because it's heard during systole and diastole. Later in life, though, from years of increased pulmonary blood volume, patients might develop pulmonary hypertension, or higher pressures on the pulmonary side. If that happens, pressure might eventually increase to a point where right-sided pressures are greater than left-sided pressures, and so the flow of blood through the PDA can be reversed. When this changes from a left to right shunt to a right to left shunt, it's referred to as an Eisenmenger's syndrome. Now you've got deoxygenated blood flowing into the aorta and generally heading to the lower extremities, since the upper extremities and head typically have arterial branches upstream from the PDA. This results in cyanosis in the lower extremities, a blue or purple discoloration of the skin that's the result of deoxygenated blood mixing with oxygenated blood. This situation is actually sometimes called differential cyanosis, since only the lower body is cyanotic. Patent ductus arteriosus can actually be treated early on. Remember how prostaglandin E2 keeps the ductus arteriosus open during fetal development? Well, the drug indomethacin can be used to close a PDA because it's a type of non-steroidal anti-inflammatory drug, or NSAID, and it inhibits prostaglandin E2. In some cases, the PDA might also be closed by surgical ligation as well.
Alright, as a quick recap. When the ductus arteriosus fails to close after birth, it's called patent ductus arteriosus, or PDA. PDA allows some oxygenated blood to return back to the lungs, but it does not allow deoxygenated blood into the systemic circulation, which means it's acyanotic. Initially, PDA causes a left to right shunt, resulting in pulmonary hypertension. Over time, as the pulmonary artery pressure increases, this is converted into a right to left shunt. This switch in the shunt is known as Eisenmenger's syndrome. PDA can be treated with the drug indomethacin, or by surgical ligation.
If you look at the heart, you've got the right and left atrium up top, and the right and left ventricles down low. Each of these pairs is separated by a wall, called a septum. A ventricular septal defect is when this lower wall, the ventricular septum, has a gap in it after development. The septum's formed during development as this muscular ridge of tissue grows upward from the apex, or the tip, and then fuses with a thinner membranous region coming down from the endocardial cushions. Voila, 2 separate chambers. If these don't fuse though, then a gap is left between the 2 chambers. In other words, a ventricular septal defect, or VSD, and the majority of these cases are caused by a defect in the membranous portion of the septum. Among babies, VSDs are actually the most common congenital defect overall, but 30 to 50% of VSDs can spontaneously close during childhood, which makes ventricular defects less common with adults. VSDs are associated with fetal alcohol syndrome and Down syndrome, and are often associated with other cardiac deformities as well. Alright, so now let's check out what happens with blood flow now that there's this opening between the 2 ventricles. I'm going to actually switch to this super duper simplified heart instead, just because it's easier to show what's going on with blood flow. Alright, so deoxygenated blood comes from the body to the right atrium, and then flows down into the right ventricle, where it now can be either pumped out to the lungs, as normal, or pop over to the left ventricle. Since the pressure on the left side of the heart is actually higher than on the right, and blood likes to flow from high pressure to low pressure, it actually prefers to just keep going onto the lungs. When oxygenated blood comes back from the lungs to the left atrium, and then the left ventricle, now again it's got 2 choices. It can either be pumped out to the body, or flow over to the right ventricle through the gap. Since now it's in the left ventricle, which has higher pressures, some of the blood flows over to the lower pressure right ventricle. So a left to right shunt has been set up, where oxygenated blood takes an extra trip to the lungs. Since there's more oxygenated blood over here, patients will have increased oxygen saturation in the right ventricle and pulmonary artery. Also, that blood flowing through the VSD can be heard as a hollow systolic murmur at the lower left sternal border. If it's a small VSD, it might be asymptomatic. As the size of the VSD increases though, symptoms tend to get more severe and present earlier on in life. But what sort of symptoms? Well, as blood is shunted to the right side, blood volume increases on the right side, which might lead patients to develop pulmonary hypertension, or higher pressures on the pulmonary side. If pressure increases to a point where the right side's more than the left side, then the direction of blood flow through the VSD can switch from being left to right to left, a condition known as Eisenmenger syndrome. Now, deoxygenated blood is escaping out to the systemic circulation and being pumped out to the whole body via the aorta. This essentially means that less oxygen is being delivered to the tissues, which definitely isn't good. Patients can present with cyanosis. Specifically, it can appear as bluish skin in certain areas, like around the lips or the fingertips. Due to the severity of these complications with larger defects, surgical closure of the VSD might be needed. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
At the pediatric cardiology clinic, 2 mothers were chatting about their kids. One mom spoke about a 5-year-old boy named Blake, who was a bluish color at birth and had a continuous machine-like heart murmur between the scapulas. Another mom spoke about her 12-year-old son, Paul, who was healthy at birth, but when he was breastfeeding or crying, his skin turned pale and then blue. As a child, Paul got out of breath easily and needed to squat down to recover, and during his school physical, he was found to have a heart murmur. Both Blake and Paul have cyanotic congenital heart defects, or CHDs, which usually start causing problems within the first 3 to 8 weeks of life. They can be broadly grouped into life-threatening cyanotic heart defects, or the less dangerous acyanotic heart defects. Let's go over 5 of the life-threatening cyanotic congenital heart defects: persistent truncus arteriosus, transposition of the great vessels, tetralogy of Fallot, total anomalous pulmonary venous return, and tricuspid atresia. Now, the first three are caused by outflow tract defects that develop during the formation of the aorta and pulmonary artery. In fetal development, the heart looks like a long tube. The top part is the truncus arteriosus, and the part inferior to that is the bulbus cordis. Neural crest cells migrate to the bulbus cordis and trigger the formation of the aorticopulmonary septum. This structure is formed when two endocardial cushions appear on the right superior and left inferior walls. These grow like a spiral, imagine a corkscrew, and they wrap around each other, forming a single septum that divides the truncus into the roots of the aorta. One root connects to the primitive left ventricle, the other connects to the pulmonary artery and primitive right ventricle. That's how blood gets routed to the right place. Okay, so if the aorticopulmonary septum doesn't form, or forms incompletely, the result is a persistent truncus arteriosus. For your exams, it's important to note that this is caused by the failure of neural crest cells to properly migrate to the bulbus cordis. So we end up with a single vessel that's connected to both the left and right ventricle, allowing oxygenated blood and deoxygenated blood to mix. This large common trunk eventually divides into the aorta and the pulmonary artery, and both carry partially oxygenated blood. When the partially oxygenated blood goes out to the body, it causes cyanosis. Okay, moving on. If the spiraling of the aorticopulmonary septum doesn't occur at all, we get transposition of the great vessels, where the aorta connects to the right ventricle and the pulmonary artery connects to the left ventricle. Here, deoxygenated blood from the systemic circulation goes to the right side of the heart and gets pumped out of the aorta again. Meanwhile, oxygenated blood from the lungs goes to the left side of the heart and gets pumped back to the lungs. So for the test, remember that we end up with two separate closed systems. Another high-yield fact is that the only way that a newborn can survive is with a patent ductus arteriosus, or PDA, an opening between the aorta and pulmonary artery that allows some of the oxygenated and deoxygenated blood to mix. But, since the PDA normally closes soon after birth, it has to be kept open to keep the newborn alive. Now there's tetralogy of Fallot, which is the most common cyanotic congenital heart defect. And tetralogy refers to four main features that you absolutely have to remember. First, a part of the right ventricle wall under the outflow tract, called the infundibular septum, is displaced anteriorly, which narrows the right ventricular outflow tract, leading to pulmonary stenosis. Second, the narrowing of the right ventricular outflow tract increases resistance to blood flow, so the myocardium of the right ventricle hypertrophies to overcome that resistance. On X-ray, the enlarged heart looks like a boot. Third, there's a VSD, a tiny hole between the ventricles that allows blood to shunt across. Initially, the left-sided pressures are higher, so blood flows to the right, but over time, right-sided pressures get so high that blood flows to the left. This is called Eisenmenger syndrome, which is very important to remember. In other words, some of the deoxygenated blood bypasses the lungs and goes to the left ventricle. Fourth, there's a displaced aorta that sits right above the ventricular septal defect, and this is called an overriding aorta. A key concept that's frequently tested is that the level of cyanosis depends on the severity of pulmonary stenosis. So unlike other cyanotic CHDs, some newborns are asymptomatic until later in life, like in the case of Paul. But these infants can have cyanotic episodes called TET spells. And remember for your exams that this is when actions like feeding or crying causes spasms of the infundibular septum, which worsens the stenosis and causes cyanosis. If a person with tetralogy of Fallot squats down, it kinks the arteries in the legs, which increases peripheral vascular resistance, increasing afterload. That leads to less blood shunting to the left ventricle and more blood going through the pulmonary artery instead. Okay, moving on. The next two disorders are not outflow tract defects. First, there's total anomalous pulmonary venous return, or TAPVR. Normally, the four pulmonary veins develop close to the lungs and then grow towards the heart to fuse with the left atrium. The main concept you'll need to know is that in TAPVR, the pulmonary veins fuse at the wrong location, usually in the right atrium or in systemic veins. This means oxygenated blood from the lungs ends up on the right side of the heart. So in order for the fetus to survive, an ASD is needed to allow blood to move from the right atrium to the left atrium, and then into the left ventricle and out to the body. Since the right side of the heart receives a lot of extra blood, pulmonary hypertension usually develops. Meanwhile, the blood that's pumped to the rest of the body is a mixed, partially saturated blood, so there's cyanosis. The final CHD is tricuspid atresia, and that's where the tricuspid valve is malformed or fails to develop entirely. If it's absent, deoxygenated blood returning from systemic circulation gets trapped in the right atrium and can't reach the lungs. The important fact to remember for exams is this is incompatible with life, unless there's an ASD, which allows blood to reach the left atrium, and then a VSD, which allows blood to reach the right ventricle so it can be pumped to the lungs. To make matters worse, the roundabout path severely limits the amount of blood that reaches the right ventricle, so it atrophies. Both the mixing of blood and the decreased pulmonary blood flow contribute to cyanosis. Now, all 5 CHDs share some common symptoms. First, there's cyanosis, which is typically present at birth or within the first few weeks of life. The exception is tetralogy of Fallot, where the cyanosis might not appear until later in life. Peripheral cyanosis is mild cyanosis in the limbs, and it's normal in newborns. Central cyanosis is where the infant's whole body is cyanotic, and it's abnormal and should always be investigated. Other symptoms of CHDs are difficulty feeding and failure to thrive. CHDs can be detected prenatally via ultrasounds. After birth, pulse oximetry, ECG, and chest x-rays can be done. But on a test, the best answer choice for confirming a CHD is with an echocardiogram. Now, it's also important to remember the heart murmurs that are frequently associated with these CHDs, since they might be the best clues you get on an exam. Since tetralogy of Fallot and tricuspid atresia often have VSD, there can be a holosystolic heart murmur at the left lower sternal border. Tricuspid atresia and TAPVR are associated with an ASD, so there's a systolic ejection murmur at the left upper sternal border. Transposition of the great vessels can occur alongside a VSD, ASD, or PDA, which presents as a continuous machine-like murmur at the left infraclavicular area or between the scapulae. For Blake and Paul, Blake was cyanotic at birth, and he had a PDA murmur, which could be auscultated at the back, so he most likely had transposition of the great vessels. Meanwhile, Paul probably had a mild tetralogy of Fallot, since he was not cyanotic at birth, and he experienced TET spells. Another clue is that he got symptomatic relief from squatting down, which increased the afterload and thus decreased the left to right shunting and increased pulmonary blood flow. And that's the pathology in a nutshell.
Hypo means beneath or under, and plasia means molding or formation. So hypoplastic means underform, or in this case underdevelop. Hypoplastic left heart syndrome, therefore, is where the left side of the heart doesn't fully develop. Hypoplastic left heart syndrome, or HLHS, is a congenital heart defect that affects the left side of the heart, specifically affecting the left ventricle and ascending aorta. Also, the aortic valve and mitral valve might be either too small to allow enough blood to flow through, or they might be absent altogether, called atresia. The exact mechanism that causes HLHS isn't known, but one popular theory is that there might be some primary congenital heart defect which reduces the blood flow through the left ventricle and outflow tract during fetal development, making that part of the heart not grow and develop normally. With that said, HLHS is often associated with other congenital heart defects. In particular, though, an atrial septal defect, which is an opening between the left and the right atria. Actually, not only do these babies usually have this defect, they essentially need it to survive after birth, along with a patent ductus arteriosus, or PDA, a blood vessel that connects the aorta to the pulmonary artery, which usually closes within a few days after birth. Let's actually switch to a more simplified version of the heart to see what happens with blood flow. So right here, you've got the atrial septal defect, which connects the left and the right atria, and then the ductus arteriosus, which connects the aorta to the pulmonary artery. And then this is a really underdeveloped left ventricle, and a smallish aortic and mitral valve. Alright, so now let's take out the septal defect in PDA. What happens? Well, deoxygenated blood comes from the body and goes into the right atrium. It then goes to the right ventricle and is pumped to the lungs. Then oxygenated blood comes back to the left atrium. At this point, blood has a super hard time getting to the left ventricle, so the pressure in the left atrium is high. Blood that does manage to get into the left ventricle is really weakly pumped out to the body. This situation obviously isn't sustainable, right? Alright, so now let's add in that septal defect in PDA. Oxygenated blood comes into the left atrium, and since the pressure on the left side is so high, it takes the path of least resistance, and goes through the septal defect and mixes with deoxygenated blood in the right atrium. It then goes to the right ventricle and is pumped out the pulmonary artery, where some of it travels back to the left side through the PDA to the aorta and out to the body. Clearly, this system isn't the most efficient way to move blood around the heart, right? But it can be enough to keep the baby alive, and sometimes even relatively asymptomatic in the hours immediately after birth. Normally, within the first day after birth, the ductus arteriosus starts clamping shut, and within 3 weeks it's completely closed off and turned into the ligamentum arteriosum. As it closes, blood flow gets more and more restricted to the body, causing cyanosis, a bluish-purple discoloration of the skin. Eventually, this leads to cardiogenic shock, and without intervention of some kind, HLHS is fatal. HLHS is often diagnosed by prenatal ultrasound, but occasionally doesn't get diagnosed until after the baby's born using echocardiography. Prostaglandin can often be given to babies to help keep the ductus arteriosus open until a staged surgery can be performed to fix the heart defects. Occasionally, a heart transplant can be done as well, but because of the complexity of HLHS, these treatment decisions are made on a patient-by-patient basis.
Alright, as a quick recap. Hypoplastic left heart syndrome, or HLHS, is a congenital heart defect where the left ventricle and ascending aorta don't fully develop. It's often associated with other heart defects and causes cyanosis, because it limits the amount of blood pumped to the body. Without surgical intervention, HLHS is fatal. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
Tetralogy of Fallot, or TOF, is a congenital heart condition where patients have 4 heart abnormalities. Here's the normal heart, with upper chambers, the left and the right atria, and lower chambers, the left and the right ventricles, as well as the aorta and the pulmonary artery. Okay, so now let's go through these 4 findings in TOF one by one. The first abnormality is stenosis, or narrowing of the right ventricular outflow tract into the pulmonary artery. And this could either be narrowing of the valve itself, or narrowing of the infundibulum, the area right below the valve. Either way, this makes it harder for deoxygenated blood to get to the pulmonary circulation. In response, and this also happens to be the second feature, the myocardium of the right ventricle hypertrophies, or gets really thick, in order to contract harder and push blood past the stenosis. This causes their heart to look boot-shaped on an X-ray. The third feature is that patients have a large ventricular septal defect, this gap between the ventricles that allows shunting of blood between them. Now, in a patient with an isolated ventricular septal defect, meaning those that don't have TOF, oxygenated blood is shunted from the left side to the right side, because the pressure on the left is higher than the pressure on the right. For patients with TOF, though, the right ventricular outflow obstruction might block the normal blood flow so much that the pressure in the right ventricle has to be really high to get past it. Well, the high right-sided pressure means that the left side of the heart actually becomes the path of least resistance, and deoxygenated blood shunts from the right side to the left side. The fourth and final feature is that the aorta overrides the ventricular septal defect. And this one's super variable. Sometimes the aorta is way over here sitting on top of the septal defect, and sometimes it's more on the left ventricular side. Either way, if deoxygenated blood is shunted from right to left, then it flows over to the left ventricle and immediately out to the body. When you think about it, the critical feature of these 4 is the degree of right ventricular outflow obstruction. With less obstruction, oxygenated blood might be shunted from left to right and get into the pulmonary circulation, where it essentially takes another run through the lungs. With more obstruction, deoxygenated blood is shunted from right to left and enters the systemic circulation. And more deoxygenated blood going to the body essentially means less oxygenation of the tissues, right? In fact, shunting can be severe enough to let the oxygen saturation fall below 80%, at which point patient's skin takes on a bluish or purple discoloration called cyanosis. Tetralogy of Fallot is actually the most common cause of cyanotic congenital heart defects, accounting for about 50 to 70%, as well as about 10% of all congenital heart defects in general. Now, it's not quite clear why some babies develop TOF, but it's associated with chromosome 22 deletions and DeGeorge syndrome. Babies with TOF often have cyanosis around their lips and fingernail beds at birth, and can have clubbing of their fingers and toes within a few months. On the other hand, if a baby doesn't have severe right ventricular outflow obstruction, the baby might not be cyanotic. Nevertheless, having any decrease in the normal oxygenation of blood can affect the baby in a lot of ways. And those born with TOF can have a range of symptoms including feeding difficulty and failure to gain weight and develop normally. Babies with TOF will often experience symptoms and cyanosis in spells, which is referred to as TET spells. So say the baby's cruising around, and therefore increasing their oxygen demand. Their heart will try to pump more blood, leading to a sudden decrease in oxygen saturation, which causes them to be cyanotic. When this happens, they'll squat down to reduce cyanosis. Why does this help though? Well, squatting down or getting into a knee-chest position slightly kinks the femoral arteries in the legs, which increases vascular resistance in the peripheral arteries and therefore increases pressure in the systemic circulation, which increases pressure in the left ventricle enough such that the pressure on the left side is now greater than the right side, and that shunt temporarily reverses, forcing blood to take the path to the lungs to be oxygenated, therefore reducing cyanosis. When patients do have a serious hypercyanotic episode or TET spell, they can be treated by keeping them calm and giving them oxygen and IV fluids, along with medications that are ultimately aimed at improving pulmonary blood flow. A diagnosis of TOF is usually made with echocardiography, which can even be done prenatally. Most patients with TOF will have cardiac repair surgery in the first year of life, where the ventricular septal defect is closed with a patch and the right ventricular outflow tract is enlarged. Fixing these two defects resolves problems caused by the other two defects. When the right ventricle no longer has to work so hard to pump blood to the lungs, it can return to a normal thickness. And fixing the ventricular septal defect means that only oxygen-rich blood will flow out of the left ventricle into the aorta.
Alright, as a quick recap. Tetralogy of Fallot, or TOF, is a congenital disorder characterized by 4 heart abnormalities: stenosis in the right ventricular outflow tract, right ventricular hypertrophy, ventricular septal defect, and aortic override of septal defect. Together, these can cause cyanosis in the newborn, and is diagnosed with echocardiography. Tetralogy of Fallot can be corrected using cardiac repair surgery in the first year of life.
Normally, the heart's set up so that the left ventricle pumps oxygenated blood out to the body through the aorta. Then deoxygenated blood comes back to the right atrium, flows into the right ventricle, and is pumped to the lungs through the pulmonary artery, where it comes back to the left atrium, flows into the left ventricle, and this whole process restarts. The great arteries are these two main arteries taking blood away from the heart, the aorta and the pulmonary artery. Transposing is when two things switch places with each other. So transposition of the great arteries, or TGA, you might be able to guess, is when these two arteries swap locations. Normally, blood flows through all these chambers and blood vessels in a big circuit, But if you switch these two main arteries, you switch from one big circuit to two smaller circuits. On the left side, blood's now pumped from the left ventricle out to the pulmonary artery to the lungs, and then comes back to the left atrium and left ventricle and restarts. On the right side, blood's pumped out the right ventricle through the aorta to the body, and blood comes back to the right atrium and right ventricle and then restarts. Blood on the right side therefore never gets oxygenated, and blood on the left side never gets deoxygenated. This isn't good, and this situation is actually called complete TGA, or sometimes dextro-TGA or DTGA. Dextro meaning right, since in this case the aorta is in front of and primarily to the right of the pulmonary artery. Alright, when the fetus is still in the mother's uterus, babies with DTGA don't have any symptoms because they're not using their lungs yet, and they rely on blood from the mother as well as a few shunts for blood flow, like the foramen ovale, a gap between the atria, the ductus arteriosus, a vessel connecting the aorta and the pulmonary artery, and the ductus venosus, which is a vessel connecting the umbilical cord to the inferior vena cava. After birth, though, when the baby has to use its lungs for oxygen, normally these shunts go away. The foramen ovale closes up and the vessels become ligaments. This essentially means that DTGA leads to death, unless there's some way for blood between the pulmonary and systemic circulations to mix. Some possibilities are having the foramen ovale or ductus arteriosus stay open, or for the baby to have what's called a ventricular septal defect, where there's a shunt between the ventricles, which is actually present in about a third of cases. Any of these allow the two independent circuits to mix blood and deliver some oxygenated blood to the tissues. That being said, this system still isn't very efficient, and a significant amount of deoxygenated blood is sent to the body's tissues, which causes cyanosis, this bluish-purple discoloration of the mouth and lips, fingertips, and toes, areas furthest away from the heart. Sometimes babies might be given prostaglandin E, which keeps the ductus arteriosus open, even though this is typically only a short-term solution and ultimately the baby's going to need surgical repair. If the shunt is large enough such that the initial symptoms aren't noticed and the TGA isn't repaired, the heart can progress to congestive heart failure. And this is because the roles of the ventricle have been switched, right? Meaning the right ventricle now pumps out to the higher pressure systemic circuit, even though it's built for low pressure systems. And the left ventricle pumps out to the lower pressure pulmonary circuit, even though it's built for high pressure systems. So in response, the right ventricle can hypertrophy or get larger, and the left ventricle might atrophy or get smaller. And these massive changes in heart structure can ultimately cause the heart to fail. Less commonly, babies can have levotransposition of the great arteries, or LTGA, with levo meaning that the aorta is primarily to the left of the pulmonary artery. In this form, the great arteries are still connected to the wrong ventricle, but it's just that the ventricles are the ones that switch places, along with their atrioventricular valves. So in this case, unlike DTGA, circulation is preserved, and therefore sometimes this is called congenitally corrected TGA. This type is acyanotic, meaning not blue. For that reason, babies with LTGA usually won't have any obvious symptoms at birth. Now, if you take a step back and look at this heart, it doesn't look that different from a normal heart. But remember that the left ventricle and mitral valve are built to withstand higher pressures, and the right ventricle and tricuspid valve are built for lower pressures. So if these guys switch roles and now the right ventricle and tricuspid valve see higher pressures than they're used to, after years of pumping against higher pressures, the right ventricle can hypertrophy, grow in size, and stretch out the tricuspid valve. And so adults are at a greater risk of heart failure. Ultimately, the cause of TGA is unknown, but there are diseases and behaviors that are associated with a higher risk of babies having TGA. Some known risk factors are related to the pregnancy, like the expecting mother having diabetes, rubella, poor nutrition, consuming alcohol, and being over 40 years old. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. The truncus arteriosus is this big structure that's present during fetal development. And later in development, it divides to form two separate arteries, the aorta and the pulmonary artery. Once it's fully developed, the aorta comes from the left ventricle, and the pulmonary artery comes from the right ventricle. A persistent truncus arteriosus is when this developmental structure doesn't divide off into two separate arteries. And so the baby's left with this one giant artery that branches off from both the right and the left ventricles, and then splits off into the aorta and pulmonary artery. Sometimes this condition is simply referred to as truncus arteriosus, or TA. The cause of this TA is unknown, although a lot of cases seem to be associated with 22q11.2 deletion syndrome, also known as DeGeorge syndrome. So let's switch to a little more simplified view of the heart. Alright, so usually deoxygenated blood comes in from the body to the right atrium, where it goes to the right ventricle and is pumped through the pulmonary artery to the lungs to get reoxygenated. Then fresh oxygenated blood comes from the lungs to the left atrium, goes to the left ventricle, and is pumped through the aorta to the body. And then that circuit repeats, right? If these two great arteries, the aorta and pulmonary artery, don't divide, you essentially have this massive artery coming from both ventricles. Notice though that this one big artery does split into the aorta and pulmonary artery. Even though they eventually split off, before that it's just one single vessel, so the oxygenated and deoxygenated blood mix. When deoxygenated blood mixes into the systemic circulation, it'll often present as cyanosis, a bluish-purple discoloration of the skin, which can be seen in the baby within the first days after birth. Before birth, though, things actually work a little differently. So what happens is that deoxygenated blood gets sent to the mother, and then oxygenated blood comes from the mother. And since they're not using their lungs yet, the fetal heart uses a few tricks, like sending the blood through the foramen ovale. What's important about this, though, is that since the fetus doesn't use their lungs yet, there's relatively high vascular resistance and therefore high pressure in the pulmonary circulation. So even though there's this huge main blood vessel and mixing of oxygenated and deoxygenated blood, the fetus actually does pretty well since the pressures in the two circuits are relatively similar, meaning that both circulations get about the same amount of blood. After the baby's born, though, the mother stops supplying blood, obviously. The foramen ovale typically closes, and the baby starts to rely on his or her own lungs. All of which leads to a decrease in vascular resistance and pressure in the pulmonary circuit, which is actually normal. That being said, though, now there's this pressure differential between the left and the right side, where the left side's higher than the right side, which is also normal. What's not normal, though, is that with TA, the blood's still able to mix, right? So what ends up happening is that since the pressure's lower in the pulmonary circuit to the lungs, blood tends to shunt toward the lungs. So more blood volume goes to the lungs and less goes to the body. This extra blood volume on the right side leads to fluid overload. And with all this extra volume, the heart begins to fail. Babies with TA therefore quickly develop heart failure, potentially within weeks after birth. Due to the severity of complications with TA, newborn babies require surgical repair, with the main goal being to restore normal blood flow through the heart. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media.